So it's my pleasure to welcome back Dr. Andrew Riordan today to speak to us on COVID vaccines and treatments. Dr. Andrew Riordan is a consultant in pediatric infectious diseases and immunology at Alder Hey Children's Hospital in Liverpool, the UK, and also an honorary clinical lecturer at the University of Liverpool. He's been an associate editor of Archives of Disease and Childhood since 2007 and was a member of the UK's Joint Committee for Vaccination and Immunisation from 2008 until 2018. He's also a member of the Christian Medical Fellowship, which is one of ICMBA's member bodies. So Andrew, it's great to have you back here. And when we invited you, we didn't quite anticipate the release of Omicron just two weeks ago, but the Lord's timing is perfect, and we're really looking forward to hearing you update us on vaccines and treatments. Thank you very much.
Thanks very much, Peter, for that lovely introduction. So I got to talk on these topics just over a year ago on these webinars. So this is a whole year later that I'm updating, and a lot has happened in the last year, as I guess we're going to see. So I'm going to talk about COVID treatments and COVID vaccines. It is, in fact, just 1 year and 1 day since the first person got a COVID vaccine outside of a clinical trial. So we'll see what we've learned in the whole year. I have to declare some interest. I'm a pediatrician, a children's doctor, so if I have any bias, then it's towards things for children, although I'm not going to talk very much about them today. I do get paid money by BMJ publishers and the Commission for Human Medicine in the UK, but I don't take money from any vaccine companies. So that's my interest declared. So for those of you who want to go and make a quick cup of tea, what I'm going to cover in this talk are these two things about treatments for COVID, and the messages are that dexamethasone is the treatment for people who've got COVID who need oxygen, and that other treatments like monoclonal antibodies and interleukin-6 blockers can be useful if they're available. And for vaccines, the benefit-risk ratio for COVID vaccines is strongly in favour of vaccination, although very rare side effects do occur, but mostly in younger people. Now, let me remind you about coronavirus. You hardly need to know anything more, do you? Here is the virus itself with these spikes. I'm sitting on the edge of it here. These things, this is the SARS-CoV-2 virus, and that causes a disease in people called COVID-19. This is the severe pneumonitis you see in people with coronavirus. And that's what I'm going to talk about, preventing or treating this severe viral infection. It's been a global problem, as I'm sure you're aware. You see some areas have more than others. Here's the latest WHO figures. It shows it's a worldwide problem. What happens when the virus comes into you? Well, initially, this graph shows you get a week or two without many symptoms and then some early symptoms, and you have a high amount of virus at that point. And then later, as the disease progresses, the virus goes away, but you get this marked inflammation. So for treatment, we need to have something that affects the virus maybe in the early phases, and then something that affects the inflammation in the later stages. And that's what we're going to look at here. So I'm going to talk about possible treatments being antivirals, listed here, and then the anti-inflammatories. Now, this talk is coming out in December 2021, and it'll be out of date pretty soon. What won't be out of date are the WHO Living Guideline, which is a fantastic resource which helps you have an evidence-based review of all the possible treatments out there. And I'd recommend you to go and have a look at that. The link is here on this slide, because they update this every time there's some new data out there. And I'm using some of their information for this talk today. So the antivirals we might use. Remdesivir is the first one we talked about, and I talked about that in my previous talk here over a year ago. There's now enough information to meta-analyze 4 randomized controlled trials of remdesivir in COVID patients. And the WHO recommendation is not to use it. So disappointing, but their recommendation would be not to give remdesivir to patients with COVID. Now, if you've looked at the US guidance in the NIH guidelines, or in the UK with the NICE guidance, you'll see that's different, because those people would suggest using remdesivir for patients in hospital with mild or moderate COVID who need oxygen but not those who require ventilation or more serious respiratory support. So why is there a difference between what the WHO guidelines suggest and what the US and UK guidelines suggest? Well, the WHO quite clearly, that their guideline development group looked at the information they had and didn't find, they found a lack of evidence that remdesivir improved the outcomes that really mattered, like mortality or need for mechanical ventilation or time to improvement. So they're not saying it doesn't work, they're just saying there's not enough evidence yet to show it really is effective enough for them to suggest it as one of the key treatments for COVID. It's also intravenously given, and it's being quite short supply, so difficult to get hold of for many people around the world. And so it's not made it into the WHO guidelines yet. Here's the summary of the evidence, which they put in this sort of format here. And this shows you, you can see down the middle here, things that don't make an important difference. So no more difference in mortality, mechanical ventilation, viral clearance, or time to improvement. So a lack of evidence for those. So let's look at another antiviral then, molnupiravir. This is another antivirus that's been designed against a number of viruses, but has effect against coronavirus. And this is an oral agent, so much more easy to administer. But people have used this as a way of trying to stop people getting severe COVID disease. They gave it to adults who were outside of hospital, who had a recent COVID infection within a few days, and had a risk factor for severe disease, like being over 60 or having diabetes or one of those comorbidities. And when they did that in this trial, the Move It Out trial, you can see that they reduced the chance of being in hospital or dying from COVID by 50%. So an impressive looking figure, but when you actually look at the numbers itself, of the 385 people who got given the drug, 28 of them came to hospital, as opposed to 53 of the 370 people who got given placebo. That's a 50% relative risk reduction, but the actual risk reduction is only about 7% there, isn't it? Small. So comments about that from various people have been that the number needed to treat to prevent one hospitalization is about 14. So you have to give the drug to 14 people with COVID at home, and you'll prevent one person coming to hospital. And if the drug is very safe and very cheap, then that's a really good thing to have. If it's not cheap, and we don't know much about the safety because it's only been out there a short time, then you have to think whether you want to do that or not. And maybe resistance will come against these antivirals quite quickly. What's disappointing is when they gave this drug to people who are already in hospital, is that it didn't improve their outcome at all. If you are using it, then there may be some interactions with other drugs that the patient is on. If therefore, I would advise you to use the University of Liverpool drug interaction checking. It's a fantastic website. You can just put the name of the drug in and the name of the treatment you want to give, and it will give you a warning if there's going to be some significant drug interaction. Again, the URL for that website is on there. All right, what about some other way of getting rid of the virus, like a monoclonal antibody? People initially tried convalescent plasma, so a concoction of all the antibody you might make against COVID, and that wasn't very successful. But these specifically made monoclonal antibodies bind just against the spike protein. Here's that spike protein again, and particularly the receptor binding domain of the protein. This bit seems to be highly conserved, and that is the bit that you can form antibody against. So a number of companies have designed a monoclonal antibody against that particular spike bit to try and stop the virus binding onto the receptor and getting into human cells. So does that help in treatment or in prevention? Well, here's the data from the recovery trial in the UK, which shows that if you gave a monoclonal antibody to people with acute COVID, if they were antibody negative for COVID, then it reduced their mortality quite significantly. The lower bar here. However, if you were antibody positive against COVID, it made no difference at all to your outcome. And so the overall difference is nothing. So only if you're antibody negative does a monoclonal help you if you've got acute COVID. Can we use it to prevent people going into hospital in the same ways? Well, maybe. Let's have a look at that. So for non-hospitalized patients with mild to moderate COVID, again, the same as in the drug trial I just showed you, people over 65 with comorbidities, and you got given it within 10 days of testing positive for COVID, will that reduce your chance of ending up in hospital? Again, the answer is yes. And here is the pictures that show that. So that the absolute risk reduction is small again, between about 2 and 5%, but the relative risk reduction between 80 and 70%, very substantial here. So these things can help you getting really unwell and ending up in hospital. Unfortunately, these first two with the gamma and beta variants, there's enough change in those to say that it doesn't actually work very well on those. And we don't know whether Omicron will be changed enough to have a difference to make these not be quite as effective. So the WHO guidelines suggest for these monoclonal antibodies, if you've got seronegative, severe patients with COVID in hospital, it'd be worth trying, or for those at risk before they come into hospital to try and prevent that. What about the anti-inflammatories? Well, the treatment that really works well, we know about for over a year now, are steroids, dexamethasone, especially in the treatment trial that was out there. The corticosteroids for people who need oxygen or have any other form of severe COVID, then the benefit of those is huge, but not for those who've not got severe disease. This came out of the recovery trial, as I said, and the number needed to treat to prevent one ventilated patient is about only 8. So this is the first drug that was shown to improve COVID and is therefore the one that we'll be using. Thankfully, this is a cheap and easily available drug, and therefore one that can be rolled out worldwide for use. Here's the evidence from the WHO guideline, and it shows that 87 fewer people in 1,000 will get critical illness, or 67 fewer with severe illness will have a problem if they get dexamethasone. The only adverse event that is increased with people who get steroids is having a raised blood sugar, and that needs to be monitored when you've got people on steroids, of course. On top of steroids, is there something else we can use? Well, there's this huge cytokine storm that occurs during COVID, and so people have tried to use some of the anti-cytokine agents, and the interleukin-6 receptor blockers have been shown to reduce mortality in a randomized, in a meta-analysis now. But these are, again, very high-cost drugs and need intravenous infusion, and they're becoming very difficult to access because people are trying to get hold of them all around the world to give to their COVID patients. The WHO guidelines, again, recommend that you should have these drugs, the interleukin-6 receptor blockers in severe and critical COVID, but that's if you can get hold of them and access them for doing that. WHO guidelines also give you advice on what treatments are not very effective. And here are two we talked about last time: ritonavir, lopinavir, and hydroxychloroquine are recommended against strongly because the data out there shows they didn't have any effect in treating people with COVID. Ivermectin, I know there's a lot of interest about, because this is a drug that's available for quite a lot of people to use as an anti-helminthic drug. At the moment, the WHO guidelines suggest not to use this except in a clinical trial because the data is not yet good enough to say it's going to be effective or helpful in COVID. And so at the moment, ivermectin should only be as part of a clinical trial. So that's a very speedy run through the treatments. There's quite a lot in there, and I'll let the translators catch their breath for a moment. And then we're going to go on to talking about vaccines, which again, as I said, we've had for just over a year. And so we've learned something about them. So how would you make a vaccine against COVID? Well, here's the virus again, and here's the spike protein I've talked a lot about. This is the thing that links into the ACE2 receptor on your cells and gives the virus entry into you. It's also the thing your immune system recognizes and forms antibody against. And so that's the thing we want to get good protection against. That's coded for by the RNA that's in the virus here that sends out the genetic code to make these things happen. Well, how could you make a vaccine out of this? Well, you could just take the whole virus and kill it so that it's dead and won't infect anybody, and then use that as the basis of your vaccine. That's what is the basis of these vaccines, the Sinopharm, Sinovac, and Valneva vaccine. That's how they've made those. Alternatively, you could just take the spike protein itself and use that as the thing which you make your vaccine out of. And that's what the Novavax and the GSK Sanofi vaccines are based on. More complicated, you could take the RNA that codes for the spike protein and then put that in an adenovirus, this green thing here, and use that to smuggle the RNA into the human cell so that the cell then makes the spike protein, and that then produces an immune response against the spike protein. That's the way that the Oxford AstraZeneca vaccine, or the Janssen, otherwise known as Johnson & Johnson vaccine, or the Sputnik V vaccine are designed to be like that. The other way would be just to take that RNA that codes for the spike protein, you cover it in some fat, some lipid nanoparticles, and then inject that, and that then gets into the cell and makes you make the spike protein, so you make your immune response against that. So that technology is what's used in the Pfizer-BioNTech vaccine, the Moderna, and the CureVac vaccine. There's a little snowflake here to remind me that these vaccines, the RNA vaccines, need to be stored at ultra low temperatures, so between about -20 and -70 degrees. So that makes them very difficult to distribute worldwide, because they have to be kept at such a low temperature for a long time and can only be out of that for a short while before you need to use them. So we're going to look at the benefits of the COVID vaccines, the adverse effects from them, and then talk briefly about whether you need a third dose or a booster dose for the vaccine. So this table gives the information about how effective the vaccines are, and we'll take them one column at a time. So firstly, I want to look at how effective the vaccine is at stopping getting any sort of COVID infection. That's any positivity in PCR in your nose or throat swab. So you may be asymptomatic, but if you're positive, then that counts as an infection. So the vaccines are about 85% effective at preventing infection with the initial strains of the COVID. For Delta in the UK, we can see that's slightly lower, between 55, 75, 65-ish, that sort of level of preventing infection. For Omicron, the new variant, we don't know yet, but people worry that it may be a little lower again. So it stops you getting infection, but won't prevent all sorts of infection. However, we get more and more important as we go right on the table here. So preventing symptomatic infections, so an infection that makes you unwell with a temperature or coughing, that's better efficacy here, 80, 90%, but again, slightly lower for the Delta variant, and we don't know about Omicron. For the really important things like hospital admission, the efficacy is really good, 95%, and that seems to have persisted despite the other variants so far, but again, we don't know what will happen when we have Omicron. Will the vaccines stop you passing the virus on to other people? Well, that's what this last column is looking at, the transmission. And the reduction in transmission for the initial wild type strains with these vaccines was about 40–45%. So nearly halved your chance of passing it on. But we don't actually know that for Delta yet in the UK, and certainly we won't know that for Omicron for some time yet. So the vaccines are very good at stopping you getting severe disease and ending up in hospital and dying, but they won't stop everyone getting infection, and they don't stop you passing it on, although they may reduce your chances of doing that. What are the side effects? Well, anybody who's had a COVID vaccine will be able to tell you this first paragraph here, that you get pain at the injection site, and then fatigue, headaches, muscle aches, fever. About 1 in 10 people get that, and quite a lot of symptoms are caused during the first day or so after the vaccine, because they're quite reactogenic. That means they give you quite a lot of these symptoms. Taking some paracetamol things seems to sort most of those out. More concerningly are the very rare reports of two particular sorts of reaction. The vaccine-induced immune thrombocytopenia and thrombosis, or VIT, which has been described with the adenovector viral vaccines, and myocarditis, which has been seen with the RNA vaccines. There are some other rare adverse effects, lymphadenopathy, certainly allergic reactions, and Guillain-Barré have also been described with the COVID vaccines. We're going to focus on those two concerning ones. So, vaccine-induced immune thrombocytopenia and thrombosis, or VIT, seems to occur after the adenoviral vector vaccines, It's very rare, maybe about 20 per million doses, particularly in younger adults. But you can get clots in both veins and or arteries, and most worryingly in the cerebral venous sinuses. So this CVST can lead to death in about 5 per million doses. So this is an issue. It's been very rare, but it's been described well enough now that we know it can be happening. It seems to happen mostly after the first dose of one of the adenovirus vector vaccines. Tends to be about 2 weeks later. Information just coming out now that this may be due to the adenovirus binding to platelet factor 4, which then triggers the thrombosis and thrombocytopenia. You have to remember, of course, that people who go into hospital with COVID have a very, very big risk of thrombosis, like 3% here. So 3 out of 100 of them compared to 20 out of a million if you get the vaccine. So the risk is much more stacked for getting a thrombosis if you get COVID than if you have the vaccine. But there needs to be a balance here, of course. This is information from the UK hematologist who looked at definite or probable cases of it. And this graph shows where they found those clots, most in the cerebral veins. I think that may be skewed because the CVST was the thing that really made people start thinking about this particular very rare side effect, and so it got picked up quite quickly. But you can see the clots in other parts of the body, and some have multiple clots. Here's the information showing the age groups. So most people were under 60 years of age, particularly 40, 50. And as I told you before, that the main time of happening was around the first 14 days after the first dose. 22% died, so very rare, but there is a mortality associated with it. What would you do if you had somebody you thought had vaccine-induced thrombocytopenic purpura? Then you'd follow the WHO guideline, which again, I've put the information for on this slide. And they would advise not to give platelets, even though the platelets are low, because that can make things worse. To avoid heparin, because this is felt to be similar to heparin-induced thrombocytopenia, and therefore that might make things worse. So a non-heparin anticoagulant, and to consider immunoglobulin treatment if you had it available. But this is a very helpful guideline if you want to find that to treat these cases. The other rare side effect is myocarditis, which seems to occur after the RNA vaccines. And this seems to be mostly self-limiting and quite mild. There'd be maybe only 1 or 2 deaths in the entire world described due to this, so very rare. But it occurs particularly more in males, especially young adolescent males. It could be about 15 to 100,000 doses. These charts show the cases that have been described in one series. So here, after the first dose, very few cases. After the second dose, you can see most cases occurred 2 or 3 days after the second dose. And most of those cases were in the blue group here, boys and men, as opposed to the red group, women and girls here. So mostly young men after the second dose with these mRNA vaccines. So with any vaccine or any treatment in medicine, we're always talking about the risk versus the benefit and trying to weigh those up and having that discussion often with our patients to say, these are the risks and these are the benefits from this particular treatment or vaccine, so that they're aware and can make a decision with us to try and pick the best thing for them. The benefits here from the vaccines against COVID are quite obvious. They stop people getting very serious disease and ending up in hospital and dying from COVID. So some very important benefits from that. The adverse events for the very rare VIT or myocarditis, which occur more in younger people, again need to be balanced carefully against the benefits we see from getting the vaccines. Here's a graph from a study looking at that, and where they worked out, well, how many cases of myocarditis would you get for different age groups? They lifted down the middle here. And then how many cases of hospital admission would you prevent by giving the vaccine, the same number of doses? So in the 12 to 17, the teenage group here, you can see there's a significant group who get myocarditis. But even at this young age group, that's still less than the number who would end up in hospital with COVID. But there's a balance to be struck here, perhaps. But as you get older, the risk of myocarditis gets much, much less, and the risk of ending up in hospital with COVID gets much, much more. So the balance skews very heavily towards the vaccine, particularly in older patients, because of their risk of getting into hospital with COVID. So most people will get 2 doses of a COVID vaccine, and that would be between 3 or 4 weeks apart, or sometimes in the UK we're given 8 or 12 weeks apart, but 2 doses is what's given people these protection. But what about people who've got a very poor immune system? Do they respond, or what should we do about them? So this study has been looking at that, the Octave trial from the UK, and they took patients who had quite marked immune compromise, who'd had 2 doses of the vaccine, and then looked at their antibody levels. And they found about 11% of them hadn't made any antibody against COVID at all. And 40% had quite low levels of antibody. However, when they actually looked what happened to those patients, the protection against getting severe disease was not bad, 74% effectiveness against getting COVID. So perhaps the antibody levels may be low, but maybe the T cells that these patients have are also being active in giving some protection. It varied what disease you had and how likely you were not to make a good response. And the ones who responded least well are those people who've had rituximab for an ANCA-associated vasculitis. Other inflammatory arthritis, again, had quite a high rate of not responding well. And you can see the others here, particularly blood cancers or people who've had bone marrow transplants, then their response to vaccine was reduced. So if you haven't responded to 2 doses, would giving a 3rd dose another bite of the cherry without improve things? Well, here's a trial where they did that. So they took patients who had transplants and therefore quite immunosuppressed. They'd received 2 doses of the COVID vaccine, and then they gave them a 3rd dose to see whether they could, that would improve their protection against COVID. And here they're looking at neutralization antibodies. That's about the best marker we've got for saying that the vaccine is going to give you some protection, probably. And so after getting a 3rd dose in these immunocompromised patients, there's a quite impressive rise here in neutralization, whereas those who got placebo got no rise at all. So many people are now recommending a 3rd dose, a 3rd primary dose, for people who've got severe immune suppression, so particularly transplant recipients or other forms of immune suppression. So it's not a booster, it's a 3rd dose just to give you a really good response in your priming dose. But we've used these for a year now, so we've really got some information about how long protection will last. That's a question that everybody asked me when we first started using them. How long will the protection last for? And we've finally got data to look at that, and I'll show that to you here. So this is a study which looks at the protection from the vaccine over time. And this top panel here shows the protection of the vaccine efficacy against any form of SARS-CoV-2 infection. So any infection at all, symptomatic or non-symptomatic, anybody who got PCR positive would then drop out and say it's not effective. So the vaccine efficacy in the real world here, it's a big population, was 70, 73, 60, 70% for the first few months. Pretty good against any form of infection. And then from about 4 months onwards, and certainly by 5 months, the protection against getting any infection, so just a PCR positive test, has dropped down quite substantially. However, they also looked at what's the protection against severe disease, so disease that would make you end up in hospital or even particularly fatal COVID. And the answer is it's got to 96%, and it pretty much stuck there all through the first 6 months. So the first 6 months, protection against very severe disease remained unchanged. By 7 months, there's this massive error bar here because there's so few patients out to this length, they couldn't really work out whether it's still giving you that good protection or not. So whilst the protection against any infection, where you're getting a bit of a runny nose or asymptomatic disease, has dropped off, the protection against severe disease ending up in hospital has remained pretty good for 6 months. But the worry is that that's going to drop off at some point. And so people are looking at, should we have a booster dose from around 6 months onwards? So the next question is, well, if you get another dose, a booster at 6 months, does that improve your immunity and your protection? So here's a study looking at that. So these are people who are over 60, that have had 2 doses of the COVID vaccine more than 5 months previously, and then they gave them another booster dose to see if that improved their protection. And they're looking at here, it's a funny factor reduction in confirmed infection rate. So what they're looking at is to say, how likely is it that you will not get infection after having that booster dose? So from about day 12 onwards, the chance of not getting COVID has reduced about 11-fold. And your chance of not getting severe COVID reduces by about 20-fold. So a booster dose certainly improves your protection and makes it even less likely to get disease, particularly much less likely to get severe disease against COVID. So therefore, lots of people who've got populations who've now had vaccines about 6 months ago are now thinking about introducing a booster dose just to try and make sure they maintain that protection. As Peter mentioned in his introduction, we didn't know when we were planning this that we'd have the Omicron variant, which has been around for the last couple of weeks or so described. And all I can tell you is this, is that there's a big question mark here. Because there are so many changes in this variant, particularly in the spike protein, even around the receptor binding domain, it may be that antibodies against the vaccines we've designed from the vaccine we've got already may not be quite as effective against Omicron, but nobody actually knows that yet. They're working on that night and day, I think, as we're talking about this. But it may be there may be some reduction, although not a massive reduction in protection from Omicron. But if that's going to be the case, then boosting people so they've got higher levels of antibodies and gives them more protection might be an important thing we should be doing. Lastly, I'm just going to briefly touch on how equitable and how just maybe vaccines have been for those to protect everyone around the world with COVID. We won't get rid of the pandemic, we won't learn to live with it, we won't deal with it well until everybody in the world is protected against COVID. If it's still in parts of the world and there's a large amount of transmission going on, then the vaccine or the virus can become resistant to vaccines because it will keep generating these variants. Sooner or later, there'll be a vaccine, there'll be a virus which is resistant to the vaccine, and then we'll be back to square one again. So we're not safe until everybody's safe. We're not protected until everyone's protected. At the moment, this is the coverage of the world for COVID vaccines in some parts of the world, North America, South America, Europe. You can see good levels of doses being given out. For some parts of the world, like Africa particularly, less than 10% of the population have had a vaccine. And that it means there's going to be risk for everybody until we've got that sorted out. The other week, we were teaching our Sunday school class, and we had to talk about justice. I found this picture here trying to demonstrate what justice means. So equality means everyone gets the same thing. We haven't even got equality yet for a COVID vaccine. Justice means that people get the things that they need so that everybody benefits. What does God want from us? Well, he wants us to act justly. And I guess we all need to think and pray how we can try and help justice and equality for COVID vaccines all around the world. All right, I'm going to finish off now. And here's a summary, which I told you I was going to head towards. So the treatments we talked about, dexamethasone is the treatment that's most effective. And you give that to people who've got COVID who need oxygen. If you can access to monoclonals and anti-IL-6 agents, then they may be helpful too in particular situations. For the COVID vaccines, the benefit-risk ratio for the COVID vaccines is strongly in favor of vaccination because they give good protection against severe disease and hospitalization. There are some very rare side effects, which are a concern, but they mostly occur in younger people. So we need to be very conscious of that with our risk-benefit analysis. I'm going to finish there and say thank you very much for listening, and I'm sure there'll be a few questions that we can take from now on.
Well, thank you very much, Andrew, and extraordinary to reduce such an incredibly complex and detailed subject to give such a clear and simple overview as you have. So thank you for your clarity and your hard work in assembling all that information for people. So let's move into Q&A. Andrew, a big range of questions here. Keep them coming in, please. But first of all, you talked about the difference between absolute and relative risk reduction. Can you just explain that? I was puzzled myself, and Liette Pion's asking the question. I'm sure there'll be lots of others too.
Okay, so I go back to that example, shall I? So there was a drug trial, wasn't there, for molnupiravir, this drug, which if you gave it to people who were at home but had risk for severe COVID, it reduced their chances of going into hospital or dying. So the relative risk reduction, and that was a 50% reduction in hospitalization. That sounds really good, doesn't it? So you reduce your chance of ending up in hospital by 50% if you took that drug. So that sounds something that's really very effective, which it is. That's impressive, isn't it? But when you look at the trial, the risk vary between the two groups. So those people who didn't get the drug, who got placebo, 14% of them went into hospital, whereas those who did get the drug, 7% of them went into hospital. So that is a 50% reduction. You go from 14% down to 7%. So that's, but actually, of all the people who only got it, you only got 7% of them less ending up in hospital than you would have done without the drug. So the absolute risk reduction is just 7%, but the relative risk reduction compared to the placebo group is 50%. So you can see why drug companies and people who want to sell you the drug say there's a 50% reduction here. That sounds really good, doesn't it? But you do have to look at the relative risk reduction and then say, well, how many people do I need to give the drug to get that effect? And in this case, it's about 14 people. If the drug is cheap and safe, then you do that, wouldn't you? If it's a really expensive drug, then you have to think, well, can I afford to do that? Is that benefit something that we can actually afford and useful for us?
Yes, and as you said, a lot of these drugs are incredibly expensive compared to, say, dexamethasone, where you're getting a bigger effect at much less cost. Thank you. That's very clear. It's not just the drug companies, but also the media that often doesn't make that clear in their headlines. The next question from Marissa Resulta in the Philippines. She says, even amongst Christians, there's been vaccine hesitancy. How can we explain and encourage our brethren to be vaccinated, and how can we prepare them for the side effects?
That's a really good question, isn't it? And a very difficult one to answer, I think, isn't it? My interest in vaccination has come from being a children's doctor and particularly interested in preventing serious infection in children. And that's been something that I guess has driven me for most of my career. I didn't want to see children get very serious infection and knew there's a way to stop that. So I've been a very keen person to get vaccines out for serious illnesses. And I guess it's this risk-benefit ratio we need to look at very hard, isn't it? That's something I think that's really important, isn't it? You have to look and say, what are the potential benefits from this, and are there any risks? And are you particularly at risk, or are you particularly likely to get benefit from it? It's weighing those things up, isn't it? And I'm not sure there's a particularly Christian perspective on it from my point of view, other than we should be looking at a more equitable and just way of trying to use our resources to protect everybody. We should be giving people the offer and the opportunity to take a vaccine. I'm not going to say they must have one. I think we should offer people the chance and try and persuade them that that would be potentially in their benefit. But have to acknowledge that there are some side effects and be aware that we can reduce those wherever possible by trying to use particular vaccines in particular age groups to avoid those side effects where we can.
Now, Andrew, you talked specifically about myocarditis and the risk being higher in the younger patient, but the risk of dying from COVID being much less. What's your recommendation as a children's doctor on vaccinating 12 to 17-year-olds? Should we be doing it or not?
That's a great question. So the Joint Committee for Vaccination and Immunisation in the UK, which I no longer belong to, but have the joy of having all these questions put to them over the pandemic, had a very long discussion about this, and they thought the benefits, the medical benefits for children were rather marginal, that it was rather in the balance between the risk and benefit ratio for that age group. Other parts of the world, certainly the US, have been very keen on doing that. And when we looked at the UK, then the chief medical officers wanted to bring in other factors. So not just looking at the medical benefits, but also the potential benefits of staying in school and not missing out on school and all those sort of things. So they ended up recommending vaccines for children 12 to 17 in the UK for a broader reason than just the sort of medical risk benefit. But I think it is one of those things you have to look at very carefully and think about, because the benefits are in the balance, I think, for that sort of age group. The older you get, the less risk there seems to be with the vaccine and the more benefit you get from it. So it's a real graded thing. So you have to think about it carefully at those sort of age groups. In the UK, it was a very, very balanced and nuanced decision. And the experts were on the fence and stuck in there. And it was the chief medical officers who wanted to look at a broader perspective and therefore give children more protection so they can do school and other important things for them.
And to push you a little bit more, how about the under 12s? Not me asking.
Yeah. Well, it's, again, really difficult decision. So the vaccines, the Pfizer vaccine is now licensed for 5 to 12-year-olds in the US and in Europe. So you're looking at that. So maybe, again, you look at the risk benefit. There are some children who may have much more risk from COVID than others. So for those higher risk children, then that might be important for them to have those. Those are children with severe neurodisability and other things like that. They seem to be the children who get the most severe COVID. But for other healthy children, well, it may be a much more balanced decision than that. But so maybe high risk children you should think about. But again, those discussions are all ongoing now because they're just becoming available for that sort of age group.
Question of boosters now, and you showed how protection against infection lasts about 3 months, I think, but against severe infection it looks at least 5 or 6 months. So what would you say about the duration after which you should be giving the booster? I know in the UK it was initially 6 months and then they reduced it to 3. And is the data clear on that, or is it really just
not yet? If you can afford to wait longer, you want to see how long the protection against severe disease lasts for. But I suspect there's not been many populations who haven't been boosted after about 6 months because people are just getting a bit nervous, particularly now with Omicron coming around. The worry is that the vaccine might not give you quite as much protection, and therefore having a higher level of antibody gives you more protection. And therefore, that's why the UK and other countries are now bringing their booster programs a bit further forward, just to try and forestall that, I think. But yeah, it's all this. We're doing it on the hoof, aren't we? We've had it for a year. So it's not bad that we've got up to 6 or 7 months data. That's pretty good, isn't it? By the time you've got the information, done the blood test, analysed it, got it out there in the journal, that's pretty good. But we're still going to be lagging behind by a few months always, aren't we?
Yeah, absolutely amazing. So Tim Tusink now from based in East Africa says a great presentation. Thanks for that. Are there any increased severe adverse effects being reported with booster doses, or is it too early to say at the moment?
Yeah, that's another good question. So people are particularly looking for myocarditis after a booster dose, aren't they? And haven't seen that particularly. Most of the boosters, certainly in the UK and other parts, tended to be in older people who are less likely to get these really rare and serious adverse effects. So we haven't seen that yet. I sit with the Commission for Human Medicine's expert working group for COVID vaccine. So we see the reports of all the serious adverse events that come through it, and the boosters so far, there haven't been any more of the really serious ones that we might worry about. So not yet is the answer, but again, it's really important you keep watching these things because that's how we detected all these other very rare but important things to pick up, because there's so much surveillance going on looking at these.
Sorry, Tim has a follow-up question about the type of vaccine we should be using for a booster. I know in the UK here, we're using Pfizer. I had my Pfizer booster a couple of days ago and just saw on the news this morning that Pfizer's just been approved as a booster in South Africa as well. Is there much data on what the best booster is and why, or is it, will any vaccine do?
So there is a study just out now from the UK. Yes, it's out now, I think, in the Lancet. New England Journal. Cov Boost was the name of the trial because it's a booster trial, and they used 7 different vaccines as boosters, and almost all of those gave some protection. The ones that we use in the UK, Moderna and Pfizer, the 2 mRNA vaccines, probably gave the best, but you got protection from almost all of the vaccines they used in the study. So if you've got a vaccine, then you should be using it, I think. But it'd be worth looking at the Cov Boost study because that's quite helpful at seeing what protection you can get from the different various vaccine boosters.
Thank you. Maybe that's a reference we could, if you can give it to us,
Yep.
we can put that in the letter that we send out.
I'll try and
people
dig that
afterwards.
out. Yeah. Mm-hmm.
So I think many people would have been struck by your slide about the difference between equity and justice, with the children of different heights looking over the bar and so on. And just to relate this to the children vaccination question again, in your opinion, if we're trying to achieve vaccine equity, do you think it's right that children are vaccinated against COVID-19 in some countries when many people who are higher risk in higher risk groups in other parts of the world are unvaccinated?
That's the difference, isn't it? What's the difference between justice and equity? So our focus ought to be on giving everybody who's got higher risk a chance of a vaccine, isn't it? And that would tend to be older people in the whole, wouldn't it? Children, thankfully, have a much lower risk of getting severe COVID. We've had a few, but not many, and many of those have risk factors that you could perhaps predict. So I think that the just thing we should be doing is trying to make sure that everyone who's at high risk is getting the opportunity of a vaccine. So children at the moment seem to have much lower risks and therefore should probably be lower down the pecking order than older adults around the world.
Thank you. Hedwin Kadrianto from Indonesia is asking, what would you say about giving different booster vaccine types with the primary and second dose? As you've said already, in the UK, people are getting Pfizer for the booster, regardless of what they had for the first one. What's the and in Indonesia, most doctors are receiving 2 Sinovacs and then a Moderna as a booster. So any thoughts on that?
I'm sure that's probably okay, isn't it? So that the Cov Boost trial, again, I'll put the link in so you can get people to have a look at the paper. They were based on having either the Oxford AstraZeneca or the Pfizer as the first dose, and then gave one of 7 different vaccines, and almost all of which seem to be effective. So probably it's fine. Having whatever you can get is likely to be very effective as a booster, probably, so you just need to look at the Cov Boost trial and make sure that's not the case for others. But I'm sure that's going to be effective having Moderna after you've had the Sinovac one.
Thank you. And another question on equity, Sharon Kane here. Any thoughts about what position Christians should take about driving and promoting the booster program here while vaccines remain inaccessible to much of the world's population? It's a variation on the one before, but in terms of a Christian voice on this,
it's a really good question, and I've had a number of Christian colleagues and others talk to me about this, because they say, well, why am I getting a booster vaccine when some parts of the world people haven't even had one? You know, why should I be allowed to get a 3rd dose when there are many people who haven't had a single dose? And they feel that that's not right, and will wonder whether they should actually have the booster or not. That's a very difficult question. It's a personal decision there, isn't it? So if you're an at-risk person, or if you're a healthcare worker, then probably you ought to be protected so you can protect yourself and your colleagues and your patients. So having the booster may be an okay thing to do, but we need to find ways to then promote other people around the world getting the same protection that we have been blessed with. And so finding ways that either UNICEF ran a campaign called Bump It Up to try and help people fund vaccines for other parts of the world where they weren't getting them. We need to find ways to be active in badgering people and in providing resources for those around the world so that everyone can get the dose that we've been blessed with having. Question
about herd immunity. given that the risk for children, especially those under 12, is so low and that they get largely mild disease, why don't we just let them derive herd immunity, let it run riot amongst the under 12s? And perhaps you'd like to comment with that on any data about the effectiveness of vaccination as against having the disease in terms of developing T-cell or antibody immunity.
Okay, so that would be one way of doing it, wouldn't it? In some ways, the UK tried to do that the last few months, that they withdrew all restrictions for children in schools and things from about September onwards, to try and you wonder whether that was their strategy to try and let all the children get it. And then they introduced vaccines for and then over 16s and then the over 12s. So there is that. You could try that, but of course there will be a small number of high-risk children who might become very unwell with that. And there's this strange condition after COVID that children get, this multi-inflammatory syndrome, or MIS-C, or in the UK we call it PIMS. So there are some who then can get very unwell with that. So it's not quite as straightforward as just saying, oh, it'll be fine, let all the kids get it and what have you. What's strange is that for respiratory virus, mostly young children are the ones who mostly get it, and they're the ones who then pass it on to other people. But for COVID, it seems completely the other way around, that young children don't seem to be that troubled by it. And the transmission is much more from adults to children, both in the household setting and in the school setting, rather than the other way around. So it doesn't fit the usual pattern we see with respiratory viruses. So it's a completely odd thing. So all these things we knew about respiratory viruses, we've had to relearn with COVID because it hasn't quite followed those same rules. You had another bit to that question, Peter, and I think I've forgotten it.
The other bit of the question was just to say that, for example, in South Africa, we're hearing that people who've had other forms of COVID before are still getting Omicron. And we know vaccination rates are quite low there, about 35 to 40%, but a large percentage of the population have had COVID. So it's really a question about the relative effectiveness in gaining immunity from getting the disease versus having a vaccination. What's the data on that?
Having the disease gives you protection for maybe quite a while, maybe 15 months. You probably know that, so you can get some reasonable protection. But again, like having the vaccine, it stops you getting severe disease, but won't stop you getting any infection, because that doesn't happen. So you can get mild symptoms or asymptomatic infection, even if you've had the infection already. So you can still then pass it on to other people, which is a problem, isn't it? So that's the issue. And with Omicron, because it's maybe different enough that you can just get a mild infection with that, even despite you having either had a vaccine or had infection yourself. That's the issue with these variants, isn't it?
But are you saying then that in general, it's in terms of stronger immunity, it's better to have had the disease than to have been vaccinated? Or is that?
I'm not sure anybody knows that, Peter. And
okay.
you would, certainly for somebody of my age, who's over 60, you'd probably have the vaccine and not the disease.
Absolutely. Yeah. Okay. Oh, Andrew, I'm sad to say that we are out of time. We're certainly not out of questions. We've got another 25 coming, and it's I just think more evidence about how stimulating the talk has been, and how people have valued this contribution, and we hope to have Andrew back again. Thank you very much, Andrew, for sharing your wisdom with us once again and doing it at such a challenging time in the course of this whole pandemic as well. Thank you once again. Thank you, Andrew. God bless you all, and we'll see you again, hopefully again shortly on ICMDA webinars.